Hello, my name is Andrew Lee, and on behalf of the American Academy of Ophthalmology, I'm happy to be here at the Space Vehicle Mock Facility with my good friends from NASA, Dr. Bill Tarver and Captain Tyson Brunstetter. Say hello to the audience, guys.
Hello. Hello, guys.
Today we're going to be talking about SANS, and maybe I'll just talk a little bit about you guys first. Can you just tell us a little bit about what you do here and what your role is in Spaceflight Associated Neuro-ocular syndrome? Tyson, maybe you could kick us off.
Sure. I'm Tyson Brunstetter. I'm a U.S. Navy aerospace optometrist detailed to Johnson Space Center. I'm primarily here to serve the SANS team as Dr. Tarver's deputy clinical lead for SANS. And with that, I help to support the day-to-day activities of the SANS team, as well as serve as subject matter expert for on-orbit ocular data collections that occur from the International Space Station. And I also help with the development, test, and evaluation of ocular devices that are deployed to the ISS for SANS work and hopefully for future expeditionary spaceflight. So it's a real privilege to be here.
Bill?
It's a real privilege to have Tyson here, actually. He's our eye specialist. I'm not an eye specialist. I'm aerospace occupational medicine. So my primary job here is actually flight surgeon. So that's kind of a jack of all trades, but take care of crew members on orbit. And my other task is to lead this SANS condition that we've been dealing with for years now. So I'm the clinical lead here at NASA. NASA has a strong research element, and we're very particular about which side of the fence we're on. So I'm the clinical lead, Tyson's the deputy, and it's a wonderful team working here.
Well, thanks, guys, for being here with us. Bill, maybe you could talk a little bit about the clinical side of SANS and let our audience know what kinds of things we're seeing in our astronauts.
Many years ago, an astronaut returned from space with disc edema. We've been looking at eyeballs for years, and we've never seen that on a return from space. So that got our attention, and that was the beginning of what we call SANS now. So we've had a few cases of optic disc edema, generally in the mild realm. But we also have other findings when we do MRI and other imaging that is like globe flattening and cotton wool spots that make us wonder what's going on. We initially thought it was kind of an IIH condition, but we're finding out we have a unique condition. But optic disc edema, globe flattening, those are biggies right there.
Tyson?
Really, SANS represents a constellation of findings, as Dr. Tarver mentioned. Really, as far as we know it now, it's optic disc edema, choroidal folds, globe flattening with an associated hyperopic shift because of it, sometimes cotton wool spots, and rarely retinal hemorrhages. And as mentioned, it's very tempting to try to compare SANS with terrestrial conditions like IIH, but they are truly different. There are more differences than similarities, and we know that SANS is really a unique pathology to spaceflight.
So, Bill, what are the kinds of things that the astronauts are reporting on station and in return to Earth?
Yes, we on the medical side are attuned to asking the astronauts on a regular basis to pull out any symptoms associated with SANS. The main thing that an astronaut might mention is the shift in vision, so a little hyper shift, right? So we have to be sure and cover them with some glasses, that sort of thing. But as far as symptoms go, that's it. They don't complain of the classic intracranial hypertensive symptoms like headache that doesn't go away, pulsatile tinnitus, no vision changes. So the symptom is this vision shift. That's it.
And Tyson, what do we have on the station and on Earth to study SANS?
Well, terrestrially, before flight, the astronauts, among many other tests, a 3 Tesla MRI is performed of the brain and of the orbits, comprehensive eye exam, visual field assessments, and all the typical vision tests that you would expect. It's what's special is on board the International Space Station because there's such limited space. It costs between $10,000 and $20,000 per pound to deploy devices to the ISS, and so we are limited to visual acuity, AMSA grid, ocular ultrasound, OCT, which has become our real workhorse. It's really changed the way that we look at SANS today. It's given us so much more objective information, but we also have fundoscopy capabilities as well as OCT multicolor imaging. When they come back, we run basically the same tests, take a look at pre-flight, on orbit, and post-flight to look for any changes.
And Bill, the astronauts are doing these tests on themselves on the station?
So, if you go to the eye doctor and you're a patient, the eye doctor tells you everything to do. But on the station, they take their own fundoscopic images. OCT, they don't run the OCT machine on themselves. But yes, they're doing most of the work themselves, like ultrasound. They do ultrasounds themselves. So it's a pretty unique situation. And they're also astronauts. They're not highly trained technicians doing these studies day after day after day. So we get excellent information back, and it's a pretty good trick.
Tyson, can you share with us what we've been seeing on OCT and on the imaging that we have on the station and on return to Earth?
Sure. The largest thing that we've noticed on OCT is the fact that the great majority of astronauts during long duration space flight will show some amount of optic disc edema. That could be very little, or it could be clinically significant, but everyone seems to have some ocular changes, including optic disc edema. Other things that we would see on OCT routinely is engorgement of the choroid. It's not uniform across the retina. It is really in different areas. Some can actually thin, some areas can thin, some can thicken, but overall we do see a choroidal thickening. And we also see, going back to the edema, that not only does the anterior surface of the optic nerve head expand forward anteriorly, but we see the posterior side near the lamina actually move posterior towards the brain, which is different than what we would expect in IIH, for example.
Bill, can you tell us what we're doing going forward longitudinally for our astronauts who have flown and also for future astronauts?
Yeah, so on two sides of the house. Clinical side of the house, we've mentioned we're doing OCTs. We do our eye evaluations 3 times during a 6-month mission. So a month into the mission, halfway through the mission, a month before they come back. And then, of course, we're doing ground-based studies pre and post. On the research side of the house, we have 2 major studies that have, one is completed and is in, will tell us what their data is, actually in only a couple of weeks, called the Ocular Health Study. And that one did what we do, but did it much more often and will give us a much better longitudinal look at changes earlier in flight and more often during flight. So we expect to use that to help decide what we do going forward. There's also another one called the Fluid Shift Study. In the Fluid Shift Study, in space, we think fluids shift up because gravity's not pulling them down. And this study is ongoing right now, and it's going to show how much the fluid is shifting and how much it may be causing what we're seeing right now. So those are the 2 main studies on the research side of the house. Long term, we see astronauts year after year after year, whether they stay at NASA or they retire. And that's where we're following them long term for a slightly different aspect of this problem, because we're concerned maybe it's a glaucoma-like loss of retinal nerve fibers down the line.
So Tyson, can you tell us what's going forward we're doing with OCT?
Sure. We've just deployed the OCT2 device to replace the current OCT1 device that's been deployed since late 2013. The main difference between the 2 is the acquisition speed. And so with the OCT2 being so much faster, we're able to greatly increase the density of the slices in block scans. We're also able to increase the number of circle scans that are collected. And so the density of the data, as well as the natural depth penetration into the choroid, is so much better that we will get much more meaningful information. Then if you take it a step further, the OCT2 device also has multicolor imaging technology, which will give us an idea of the depth of any lesions that we see, whereas standard fundoscopy, which we've used in the past, doesn't quite give us that same information. So we're very excited about the future of OCT data.
So Bill, could you just wrap up for our audience about how this impacts our future missions, including potentially a manned mission to Mars?
So the good news is that so far our conditions that have the optic disc edema or any complaints is kind of in the mild realm. So for a 6-month mission, we think we have limited risk. But what we don't know is extended missions, 1-year missions. And a Martian mission is supposed to be a 3-year mission. We have no human data in 0G, and we can't tell you what might happen. And our main concern is during a mission, they may lose visual function. And if you can't complete the task, all sorts of things are at risk, mission and personnel-wise. The other part of that is the longer the mission, is it a longer or greater risk when you come back down the road? Are you at greater risk for loss of visual function as well? Again, the good news is we're not seeing that, but we have relatively short duration missions under our belt, and we have much longer missions to come.
Well, I want to thank Dr. Brunstetter and Dr. Tarver for taking the time from NASA to spend it with our audience at the American Academy of Ophthalmology.